Thank you for coming. My name is John Heiss. I work at the National Institutes of Health, and I'm a neurosurgeon. And that's a picture there of the clinical center at the National Institutes of Health, and that's on a campus with many other research buildings. I'd like to talk about our Syringomyelia natural history study. And it's a prospective study. And the difference between prospective studies and retrospective studies is that prospective studies, you decide beforehand what you're going to do. In other words, the study tests and visits, and people have a set schedule. In other words, in this study, people get MRI scans at the entry to the study, at their entry to the study, 3 months later, and then annually for 5 years. So it's a 5-year study. A prospective study, you have a study hypothesis, you have a statistical plan, you have to decide how many patients you need, and the study enrollment continues till you reach a target. And before you start, you have to get approval from an institutional review board, because the board has to agree that the study is worthwhile and it's worth patients' time to participate. Retrospective studies are usually reviews of clinical data that's already been accrued, and the tests and visits are done on a clinically necessary schedule generally, and the study hypothesis is stated after the study ends, and the statistical plan starts then. And usually retrospective are thought to be inferior because you pretty much know what you found in that study, and you can adopt a statistical plan that proves what you already think. But that being said, these are the levels of research. I mean, you can have randomized controlled trials like they've had for some of the Chiari and Syring studies. So that's level 1 evidence, but what we're talking about here is prospective cohort studies. So that'd be level 2, 1 step below, and retrospective would be step 3 as far as the evidence hierarchy and how much you can believe it. Well, we're always skeptical, especially of other people's results. So why did we do this? Well, as some of the people in the audience have said, the natural history is really not known. I mean, it's like, what's going to happen to me over the next few years? And it's not clearly known. We can make some predictions. And it seems like we have disease stabilization with the treatment in most patients, but most people don't improve that much. So why is that? And some patients deteriorate on a delayed basis. So if you do a study and you only follow people 3 months and they deteriorate 3 years later, that person is called a success in that study. But if you followed them longer, you would see that that wasn't the case long term. And as pointed out by audience members, natural history of patients with syringomyelia without a neurologic deficit or without a lesion like a Chiari malformation, it's uncertain. Like, how am I going to do? What's the future hold for me? So we wanted to identify factors that influenced syringomyelia progression and affected the response to surgical treatment. And we want to acquire knowledge and want to make better recommendations to future patients with syringomyelia about optimal surgical and non-surgical treatment of their conditions. So we enrolled 180 research subjects. I don't know, I didn't see anybody from the study here. Maybe they've had enough of me. But patients with syringomyelia or patients who are at risk for developing syringomyelia, including patients with Chiari 1 malformation or patients with pre-syringomyelia. Those are patients who have swelling in the spinal cord but haven't formed a syrinx yet. So it's a prospective study that was would collect data over a 5-year period for patients with syringomyelia, patients at risk of developing syringomyelia. Only people with a neurologic deficit would be considered for surgery. And we thought that we'd have some people who would refuse surgery. We'd say, well, you need surgery. And they say, well, I'm going to see what happens. So we could compare the people we operated on with the people who we would have operated on if they would have agreed to it. And then in the patients with syringomyelia, but without a neurologic deficit, in other words, they don't have any weakness or sensory loss. Good morning. Then we'd compare their findings 1 year after entry to the study, how they were doing, if there was any change over that year. And if somebody developed a neurologic deficit, then they'd be offered surgical treatment, which is standard care. So we'd also collect other data about syringomyelia, like blood tests and so forth. So we have to declare beforehand what we're going to look at, and the primary outcome would be change in motor strength. And the other thing would be change in the maximal syrinx diameter between the surgical candidates and the non-surgical candidates. And we didn't have any children, and that's because bringing a child to a study for 5 years without any known benefit other than getting knowledge, that really wasn't considered to be appropriate by the IRB. And the other thing is, if you start out at 14, you end up at 19, so it's sort of a mix of children and adults. So these are the study groups there. All right, so we had 180 patients that were enrolled. 10 were screen failures. In other words, they went through the MRI and so forth, and they either didn't have Chiari, didn't have the type of syringomyelia that we're looking at it in the study. Then 170 were eligible. We've had 86 who've completed all 5 years, done all the study visits. 19 who are active. The study finishes in June next year. And then we have 24 withdrawn, 38 lost to follow-up, and 3 who are deceased. And none of them died during surgery. They died from natural causes and not from syringomyelia itself. The COVID pandemic really threw a monkey wrench into the study, because in a natural history study, people are coming back, and the study's for knowledge. It's not necessarily to help an individual patient. So we couldn't justify bringing people back and giving them a higher risk of getting COVID. So we had to suspend visits through the COVID pandemic. All right, so we have the syrinx without Chiari, malformation type 1, and that's just a syrinx, but no Chiari up there. Chiari with syrinx, you have the Chiari there and a syrinx, and I didn't get it together to get the Chiari with no syrinx. So anyways, we'll go through the primary and secondary outcomes, but in a study like this, you have a good deal of data, and we had the opportunity of having a graduate student who worked with Dr. Frank Loth, who's an expert at measuring structures in the brain. We had the opportunity for him to come to the NIH for a year. And so he used Dr. Loth's method to do what's called morphometrics. In other words, he measured the areas around, this is the brainstem, and this is the cerebellum. And this is before surgery, and this is after surgery. And this is the tonsils right here, the cerebellar tonsils, and this is a small syrinx. So we wanted to see how things changed from before and after surgery, and this was about the least amount of herniation we had in this study, but it was over 5 millimeters. And so we did it in a very, we did it the same way every time, and it was what's called semi-automated method. In other words, it wasn't some person who says, no, it's 1, no, maybe 2. It was the computer would come out, spit out the answer. And so we get this, what's called a midline MRI cut, and then the computer would have its way with this. And so here's area one is in front of is right here, okay, an area which is posterior to PCF, posterior cranial fossa. Then you have the anterior space, which is here in the blue. Posterior CSF is with a 3 right here. Cerebellar height is this height here. Total dorsal width is back here, number 5. That's just this line here. 6 is ventral CSF width. And why we're hung up on this CSF width is because if the width isn't wide enough, you don't get good CSF circulation. And poor CSF circulation is thought to lead to some of the syringomyelia and some of the headaches and so forth that people get with Chiari. So let me just go through what we found. For the area 1, which is here, see, before surgery, there's really very little CSF behind the cerebellum. So area 1 enlarged, went from 50 cubic millimeters to about 200, so it expanded considerably. However, in area 2, which was in front, anterior, in the patients without syrinx, it really didn't change. And this is before surgery, this is 3 months after surgery, and then this is every year for 5 years. So those are all MRI scans each year for 5 years. Is the posterior cranial area 3. Which is here. That expanded too. And so what you want with successful surgery is to get more space behind the tonsils and not a very constricted space. So you don't want a cork in a bottle look. You want a more open look where the CSF can get by. Interestingly, with Chiari with syrinx, their anterior space did expand, but it was only significant for these 3 time points. And length 5, which is here, behind the medulla to the duroplasty, that expanded as well. The occipital bone, that became shorter because we remove it, so it's only from here to here. And the length 6, which is here, that expanded only at the 3-year point was that significant, the ventral CSF width. The length 7 was smaller. That's tonsillar position. So that means the tonsils went from down there and they went up a little bit. And so for all the patients in the study, they significantly went up, but they went from 8 millimeters below the foramen magnum to, at the end of the study, about 5 or 6. So and the occipital bone, as I said before, is shorter. And this angle here, this cerebellum clivus bone angle, if you get a decompression that works, the cerebellum rotates because the bone holds the cerebellum down here. And once you take the bone off, the cerebellum rotates posteriorly in a sort of a curve, like you can see a curve like that. And it goes into the space that you've made with the duroplasty that some of the surgeons have shown you. So the cerebellum wants to take a more normal shape, even after being compressed for so long. All right, so as well as doing those morphometric measures, we also looked at quality of life in Chiari patients and patients in this group. And the Karnofsky scale is a a scale of that. 100's normal and 0's dead, and most people are somewhere in between. But you know, we don't fill this out. We let the patients fill this out, and like I go in the room and I'm thinking this person's doing great. She's 100, and then they fill it out in their 80s. You know, so see, this is minor symptoms of disease, but able to carry on normal activity. That's a 90. Normal activity with effort, that's 80. Cares for self, unable to carry on normal activity or do active work. You can see that that's not a great quality of life, and then requires additional assistance, but cares for most of their needs. So that's really unacceptable for, you know, I wouldn't call that reasonable quality of life. So for the patients entering the study, they were around 80, and they improved at the earliest visit, and then they maintained that improvement over the next 5 years. As far as the pain went down at the first visit after surgery, and perhaps went down, the average pain, over time. As far as continuous pain, this is a different type of pain. The surgery helped that pain, but you could see it's not down to 0, you know. 3, this is on a 10 scale, so a 3 is moderate pain, and 1 is mild pain. Or actually 4 to 6 is moderate pain. 1 is really, really mild pain, and 3 is almost moderate pain. And so you can see pain went down after surgery. And there are all sorts of different types of pain, and I didn't break out here the syrinx patients and just the Chiari no syrinx. I think you guys know that. And let me just say that the non-surgical and surgical groups, and this doesn't include all the patients, we have to finish all the analysis, but the non-surgical group of the syrinxes were a little bit smaller. With the Chiari with syrinx, they were a lot smaller. And Chiari without syrinx, they didn't have a syrinx. But you can see their Karnofsky, you know, the average for a surgical syrinx without Chiari is 76. Chiari with syrinx, 66.7. So these people are quite severely affected, and their quality of life is not where you would like it to be. And Chiari without syrinx, the quality of life was a little bit higher. All right, so we haven't analyzed a primary outcome measure. That's considered a unplanned interim analysis, and if you do that, basically you ruin your statistical plan. It's sort of like looking at the bride before the wedding. It's not allowed. So we haven't done that. But for the secondary outcome, we've taken a peek, because that doesn't determine if the study is positive or negative. And so for the patients who were non-surgical, their syrinxes really didn't change over time at a year. The surgical patients, most of them, the syrinxes became smaller. Some of them didn't become smaller, and those are primarily the spinal syringomyelia, because we had many patients who had multiple surgeries. And whereas the Chiari patients, we didn't have to reoperate. The spinal syrinx patients, we did. All right, so this is the bottom line. All patients with syringomyelia and or Chiari had pain, and most had reduced quality of life. The syringomyelia pain persisted over time and responded incompletely to surgical treatment. And if you have a syrinx, the syrinx causes injury to the central spinal cord. You can't regenerate, so that you need, so you can lose some function because of that, obviously. The commonest problems in patients that caused disability were headaches, pain in the posterior neck and shoulder girdles, weakness, sensory abnormalities, and imbalance. Surgical treatment halted the neurologic progression And we were able to observe most patients, and most patients remained stable. And some actually improved that we didn't operate on, and they didn't progress. So we thought that the criteria we used to decide who would need surgery and who wouldn't were appropriate. And adjuvant non-surgical treatments are needed to relieve residual pain and disability, because if you measure pain, that's, in some patients they have pain, but they're taking NSAIDs or other medications, Neurontin, just a variety. And we kept track of all those medications. So what's the value of a natural history study? Well, it gives you ideas for where to go next, or for a study that would give you level 1 evidence, and it gives you questions, because questions will always point you in the way of other research. Like some of the questions that were raised to me by the study is, would restricting bony decompression result in less cervical muscle pain? And how could the neurosurgeon reduce muscle injury during surgery? And like Dr. Bez, he was talking about posterior fossa reconstruction, with that window he could ultrasound through. Would that be beneficial? We don't know. I mean, they all seem like good ideas, but we'd have to prove them. Selecting patients, can a neurosurgeon accurately decide who have stable symptoms and who will remain stable and don't need surgery? That the study raised that point, but you would need a hypothesis-driven study based on that question to really answer that question. And we found that patients with syringomyelia with extensive scarring or previous surgery were the only patients that required reoperations by us. And that raises a question, what drug treatment or surgical technique could reduce the risk of surgical scarring with surgery and continuous or more reoperations? So this is one thing, one surgical adjunct that we use. We use the spinal endoscope to break up some of the adhesions in people who would have adhesions over multiple levels that weren't amenable to like laminectomy over all those levels. All right, I'm up here representing a team. It takes a lot of people to run a study, and all these people are much more reliable than me, I'll tell you. They work very hard, and we have residents too, and we have a very nice hospital and nurses in the hospital that take care of our patients too. So thank you for your attention, and I'll answer questions in the question and answer session. So thank you.